Hello. Well, I'm here with Paul Johnson from the Institute for Fiscal Studies, and he is the lead author of Chapter 2, which I guess we can loosely title It's the Money. You can't have a conversation about health or social care without the money. What would you say were the main themes in your chapter?
Well, you're right. I mean, it is about the money. We spend a huge amount of money on the health service, over £150 billion a year, much the biggest bit of government spending, and that's rising, and over time it's risen dramatically over the last 20 years. It will rise over the next 20 years. So the first one is the money. Secondly, people's health actually matters for the rest of the economy. It's not just money going to the health service. It's also, if the population is healthy, they're going to be producing more and there'll be more money around. And actually one of the challenges we face is that particularly people who are not doing so well in the labour market, people with relatively low levels of educational qualifications, are actually, if anything, becoming sicker over time, certainly more likely to be on sickness, disability, incapacity benefits. So sorting that out is going to be terribly important going forward as well.
And in one of the other chapters, which we're also reviewing, the social determinants of health, the deprivation ratios against sickness and ill health and poverty, it's inextricably linked.
They're very closely related. I mean, it's not, in a sense, clear always which way the causality runs. Certainly, people who are very poor tend to be sick. People who are sick tend to be poor, and obviously if you are off work, that's going to mean you've got lower income. But that correlation is very strong. And one of the things I think is most shocking over the last 20 or 30 years is if you look at people who are on incapacity benefits, those are the benefits you get if you're too sick to work. 20 years ago, it was overwhelmingly going to people in their late 50s, early 60s. Now, a 30-year-old with low level of education is much more likely to be on those benefits than a 60-year-old with a high level of education. So the relationship between social class, educational attainment and so on, and health is becoming stronger, and actually the relationship with age in some sense is becoming less strong.
Has come through. They will have had good education, a good job, a reasonable diet. They haven't got the legacy of an industrial past. They're likely to be net savvy. We're dealing with a whole different group of people. I mean, dementia aside, they'll be a lot fitter and a lot more active for a lot longer.
Well, in the end, when they get to the end of their lives, become frail and sick, and that's one of the, in a sense, is the difficulty about funding a health system. In anything else that you look at, things get better, productivity goes up, it gets cheaper. In the health system, as things get better, productivity goes up, people live longer, it gets more expensive because you have to look after them for longer. But you're right, the longevity is rising.
And we're pushing it further down the track.
It's risen a lot, actually. It's risen unexpectedly. I mean, 20, 30 years ago, no one had any expectation that we'd live as long as we are living. A lot of people are living healthier lives, but not everybody. Some people are still living longer, but long periods with poor health as well.
Yeah. Education, economic productivity and poverty. That's almost like the stripe in the toothpaste that goes through your entire chapter, isn't it? You return to that again and again.
The more productive we are, the more we earn, the more we can spend on health, but equally the healthier we are, the more productive we're like to be as a nation. And actually, the more educated we are, the more likely we are to be healthy and productive. Right. So you need to make all of those things work. And I think part of the issue with government policy is that everything's done in a silo. We look at the social security system, we look at the health system, the education system, tax system, and so on, and try to solve things one bit at a time. It's actually sadly even more complicated than that. It's all a big system.
When Jeremy Hunt was the Secretary of State for Health, he managed to persuade Number 10 to move social care into health, so it's the Department of Health and social care, but of course the money stayed with local government.
Yeah, I mean that changed, there was a change to the name of the department. There wasn't an enormous amount of change to policy. Social care, as you say, is delivered by local authorities, and one of the problems they face, of course, is they have seen sharp reductions. Yeah. I mean, their health spending has continued to rise, and actually rise quite fast over the last decade. Spending in local government has gone down by at least a fifth, and social care is easily the biggest bit of local government spending.
Which I suppose brings us on to something you don't directly address in your chapter, but there is the hint of, okay, well, what do we do next about this? And the absence of the Green Paper.
Well, we've been waiting for a social care green paper for almost as long as I can.
It's going to be brown on this one.
Almost as long as I can remember. I mean, one of the problems here, and I think this is one of the, this is a difficult political time. Obviously, the government doesn't have a proper majority. It's mired in Brexit. There's not much money around. But this is, something that's been kicking around as a problem, and governments have known it's been a problem for more than 20 years. And it's one of those problems. You look back at the good days, the good times, the 2000s, when there was a big majority and lots of money around, and it wasn't dealt with then. It's way harder to deal with it now, when there's no majority, no money, no focus. So, we might get a green paper this year, but it'll be pretty green. I don't think we'll actually get much in the way of real policy change in this part.
Just putting on your sort of international hat for a moment, is there anywhere that you would say, do you know what, they've kind of got it right?
On social care?
Yes.
There are certainly other countries where they've put in place a more comprehensive system and specifically raised tax or social insurance to pay for it. So the Germans and the Japanese have both done that. They said, look, this is an increasing amount of spending over time. We know it is. And within our social insurance system, we're going to raise extra money to deal with that. Now, different countries do these things very differently. There are some countries which are much more than we are, leave it to the family to deal with, and there are others that are moving much more towards responsibility for the state. We're in a sort of, this sort of halfway house, really, where in principle we say it's the state's responsibility, but in practice, for many people, it ends up falling either on their family or on huge amounts of money that they need to spend themselves.
I mean, it's mooted, isn't it? They're thinking about taxing the over 40s or a new tax threshold as you get older to pay for, because when you get old, you're going to pay for getting old. What, in terms of revenues generated, what does that actually give us? Does that work as an idea?
It depends what you want to do with social care funding. I mean, over time, we certainly have to spend more, and if we want a system which doesn't leave people at risk of losing a life's worth of assets and saving, it's potentially significantly more, maybe £10 billion plus. Now, all sorts of different ways you can raise that kind of money. There's certainly something to be said for social insurance contribution for people who are receiving occupational pensions. There's certainly a case for changing the inheritance tax system. There's certainly a case for changing the way that we tax housing. So there's all sorts of things you could do in the tax system which would raise money and in some sense at least look fair. I'm not convinced by the idea of, for example, putting a levy on people in work over the age of 40 on a particular level of earnings. That seems a little unfair. If you're earning £30,000 at age 40, you're probably worse off in your life than someone who's earning the same amount when they're 25. And you certainly don't want a system which is hitting people in work in their 40s and 50s, but not affecting the generation currently retired.
All roads lead back to us all paying a bit more, don't they, really?
I think they really do, whether you're talking about health or social care or anything else. There's really no point pretending, as some do, that you can raise vast amounts of money from big companies or the very rich or someone else. If we want a better social welfare state, if we want to be running a welfare state like the French or the Germans or the Scandinavians, they don't do that by slapping huge taxes on companies or getting vastly more from the mega wealthy. They get it from a broader set of taxes right across the population. And if we're honest about this, we need to say the same. If we want more money for health and social care, then actually we're all going to have to pay a bit more.
Another very interesting point you make in your chapter is the state pension threshold rising. And I guess if you look back at the history of the state pension, 65 was about right because people didn't live a lot longer than 65. But now you're 65 or 70, you might live another 10, maybe 20 active years. So there is an argument, isn't there, for shifting that threshold.
Yeah, the state pension age is actually rising at the moment. It's rising towards 66 for men and women by next year.
It's only a year.
And then it'll go to 67 in the mid-2020. So that's actually a very small increase relative to the change in people's life expectancy. So just over the last 20, 25 years, life expectancy at age 65 has gone up by several years. So that increased length of life has all been taken in increased periods on the state pension, increased periods in retirement. So the case for a higher state pension age is pretty strong. The issue then is, are people not just going to live long enough, but be healthy enough and be able to work effectively and so on in order to do that?
And pay taxes, and we have a health service that excuse me, has often portrayed us on its knees. We see pictures of ambulances queuing up outside hospitals. We hear stories of people in domiciliary care, which is very poor. We hear stories of very poorly run care homes. It's not really that we can say to the public, you pay your taxes, we'll give you a great offer. We don't actually do it.
In some respects, we don't. I mean, if you look across sort of international comparisons, our health outcomes, our health services, despite what anyone says, it's not the best in the world.
Because so often the Commonwealth Fund report is cited, isn't it, as saying the NHS is the best in the world. Well, it's the best of a lot of things, but actually when you get to the chapter that says outcomes, we're last.
Yeah. In terms of the quality of care, it's not the best in the world by a very long chalk, and a lot of people, when they experience it, are, often the medical care at the end can be quite good, but the process through which you get there.
Well, it's interesting about cancer outcomes, isn't it, really? Because the Eurostat collect the data on cancer outcomes. It's not collected on a uniformly, in a uniform way. Germany collect their data in a different way to France and so on. And if you actually look at our cancer outcomes from the point where you start to get treated to when you've finished your treatment, it's very good. It's the entry bit that's so difficult. And other countries have different aspects or different front doors to get people in for treatment.
All of that extra spending on the health service over the last 20 years, all of the extra doctors, actually, almost twice as many doctors in hospitals as there were 20 years ago. There are fewer GPs per person today than there were 20 years ago. So despite all of the rhetoric you get from politicians on both sides about the importance of community care, of primary care, of GPs, of access, actually that's the place where there's been the least investment and the least access, and that entry point, I think you're right, really is probably our biggest problem.
What is it, 93% of first contacts are through primary care for under 11% of the budget or something? It doesn't make sense. But I suppose the other thing is the primary care model broken?
Yeah, I mean, we've still got sort of a GP primary care service based on, very obviously based on the deal that Nyron Bevan reached with the doctors in the 1940s. So this is, and always has been, a completely privatised bit of the health service. These are private partnerships contracting with the health service, often one or two-handed practices, often many of which are very ineffective, but also really very well paid in a way that allows people to work part-time and retire early, and so on. So you've got this kind of lack of central control. You've got a lack of coherence and bringing people together into effective clinics, and you've got a pay and pensions package which is not giving the right balance in terms of the amount that people are willing to put in.
A self-employed doctor and a state pension.
It is an extraordinary deal.
It is. We won't go there. Paul, it's so interesting to talk to you. It's a fascinating chapter, it really is, and we've only just scratched the surface. It's full of really interesting data, facts, figures and graphs and stuff. If that's your thing, it's chapter 2 is for you. Paul, thank you very much.
Thank you.